is dietetic specific, meaning we want to improve upon the skills and know-hows of dietitians by way of the aspect of their practice. So it doesn't mean that maybe the nutritionists who cannot join. It's a CPD open to all who have subscribed to GAND CPDs, but it is dietetic specific so that the speaker may not want to start from the first principles. The speaker will be building on what's the professional knows already. So whilst it's dietetic specific, it's still open to all who may want to join to upgrade their knowledge in this field of practice. Okay, so we have about 44 people online already. It's a very great start, and we want to kick the ball rolling right away. Today's topic is very, very, very important and crucial to the practice of all dietitians. And I believe that by the time we'll be done, we will be able to have learned one or two things that will make us upgrade our documentation. In fact, as the practice is going on and as we are pushing to regulate ourselves very well, how we document, and even now that many of our hospitals are moving from the manual folders to electronic folders, our documentations are known and seen by all. And it's important that they see our documentations as that of professionals, real professionals. So I wouldn't talk much. I would introduce the speaker for this session. And after that, he would begin sharing his slides and start with the presentation. I think Mr. Maxwell Bisala Conlan, RD, is not a stranger to the dietetic fraternity. For us as dietitians, almost all of us would have met him one way or the other, or would have listened to him either on social media or on TV or radio. So I would want to give a brief introduction of our speaker. Medical documentation using IDN terminology and NCP and ADIME. So very important that we write the same language that all colleagues will understand ourselves across the divide. So Mr. Maxwell Bisala Conlan is a senior dietitian at the University of Ghana Hospital. He has a background in dietetics and a master of public health from the University of Ghana with 8 years working experience. He is also a nutrition consultant for Executive Heart Center, E&E Medical Center, Sonia Nabita Foundation, Ashesi University Health Center, and a part-time lecturer at Oak City Nursing School. RD Maxwell is a young, enthusiastic professional who is committed to improving the lives of people through health promotion and education. His interest is improving food environment. His interest in improving food environment has inspired him to partner with Tasty Treats Ghana, one of the biggest food service companies in the University of Ghana, to set up a special diet services which provides healthy meal alternatives to people who want to eat healthy or living with chronic diseases. RD Conlan is also a public health nutrition researcher who is currently working with a team of other researchers from the University of Ghana School of Public Health to evaluate the World Bank improved feeding practices in the first 1,000 days across 3 districts of Kintampo, North, Setre East, and Katsina Nankana in Ghana. RD Conlan has vast experience in TVET, curriculum development, and recently led a team of other consultants to develop a TVET curriculum nutrition program for sports trainers. Ladies and gentlemen, without any other further ceremonies, I would want to welcome and introduce to you our speaker for today, Mr. Maxwell Bisala Konlan, RD, Senior Dietitian, University of Ghana Hospital, Lagos. Thank you so much. RD Konlan, please take over.
All right. Thank you so much, my able chairman, for the introduction. Good afternoon all to all learned colleagues and senior colleagues on the platform. I would first of all want to thank the GAND executives for the opportunity given me to lead this discussion. I want to thank you for all the good work you are doing for our GAND and for the work we are putting to improve our practice as dietitians and nutrition professionals. So today my assignment is quite simple. So my assignment this afternoon is simple, is to share with you how we can use the ADIME nutrition care process to be able to document and also help refresh our knowledge. So it's going to be more of an interactive session. When we are done, I would give out the opportunity for us to ask questions and interact and see how we can possibly abreast ourselves in terms of our knowledge, in terms of the practice, as far as dietetics is concerned. Can you hear me, please?
Loud and clear.
All right, thank you. Thank you. So like I said, so the topic is medical documentation using the nutrition care process ADIME approach and the International Dietetics Nutrition Terminology. So by way of outline, I am sharing my slides now. I don't know if you can see it.
Yes, you can see your slides. If you can put it in the presentation mode.
Okay, okay, great. I think it's fine, right?
Yes, it's fine now.
Okay, all right. So we'll look at a brief overview of the nutrition care process. We'll look at why the NCP and why the ADIME approach. We'll look at some steps in using the NCP, using the ADIME model. Then, just as our chairman was saying, we'll look at hospital information system and the NCP. We'll go on to look at some practical case studies, and then we'll have an interactive case studies. After that, we would share our ideas, questions, and additions as we bring the presentation to an end. So by way of presentation outcomes, at the end of the presentation, we should be able to refresh our knowledge in using the nutrition care process ADIME model. We should be able to demonstrate the understanding of the components of nutrition care process. And then we should be able to document the nutrition care process using the ADIME approach. So these are the presentation outcomes that I would want us to be able to achieve at the end of this presentation. I'm sure, most of us as dietitians and nutrition professionals, we've gone through this process before. So it will just be more like a refresher knowledge and to add on to update ourselves on how we can use this approach very well to be able to provide quality care to our patients. Now, I would want us to look at some, key terms. So NCP simply means the nutrition care process. The ADIME is an acronym that stands for assessment. So the A is for assessment, D is for diagnosis, I is for intervention, M is monitoring, and then E is evaluation. And then when we say IDNT, we are talking about International Dietetics and Nutrition Terminology. So these are the key terms I want us to take note. As we go through the presentation, we'll be using most of these terms as much as possible. So the nutrition care process is the model used by nutrition professionals to be able to help us provide quality care. Then the ADIME format is a standardized documentation process using the nutrition care process. Okay, so ADIME and NCP are more synonymous. So the process is the NCP, then the ADIME format is the documentation format that you apply when using the nutrition care process. Then the International Dietetics Nutrition Terminology is a standardized language that is used when you are using the NCP and the ADIME formats. So basically, that is what these key terms seek to explain. Now, let's look at an overview of the nutrition care process model or the ADIME model. So in 2002, the American Dietetics Association came up with a committee for the committee to come up with a standardized practice or process in which nutrition professionals, that is dietitians and nutritionists, would be able to use to give quality care to their patients. And the committee came up with the model, and these were the things that they considered to be able to come up with the model. One, it has to be scientific based, so it was solely based on reviewing literature and look at what is the best options for dietitians when it comes to patient care. It is based on evidence based, and based on the committee reports, they realized that the nutrition care process that they were bringing actually helped improve outcomes of patients and was more professionally recognized. So we have other professionals in the other fields, like in nursing, who also have their own care process. We have the medical field, we have the physiotherapy. So it was also important that the nutrition professionals also come up with their standardized method of ensuring that they are taking care of their patients. And that is how the nutrition care process came about. Along this process was to come with a standardized language alongside which can be used for the nutrition care process, so that we all have our language that we are able to use. Every profession has its language. And so it came with a standardized language. So as we go through, we'll be looking at the standardized language as well, which is the IDN I was talking about. Now, what is the nutrition care process? So the nutrition care process model is a systematic problem-solving method that helps food and nutrition professionals think critically and make decisions that tackle practice-related problems. So one good thing about the nutrition care process is that it's systematic. Systematic means that it's a systematic problem-solving approach. It's well-structured. So it's not just a process that just came out. Everything that was done was based on research. So it's well-structured, it's in an orderly manner, and it also helps the professional to think critically and make decisions that will tackle practice-related problems. What it means is that if you therefore use the nutrition care process, carefully and using it the right way, you are likely to get the best outcome for your patients. And it is designed for use with patients, clients, groups, and communities of all ages and conditions of health and disease. So, it does not discriminate between a child and an adult. It's the same process that you use for all groups of people and all conditions, and is likely to give you the best outcome in terms of practice. Now, the nutrition care process, like I said, is structured. So the structure is such a way that, one, it helps us to improve the consistency and quality of individualized care. Okay, it helps us to improve the consistency and quality of individualized care. Consistency in a sense that if we are two dietitians, it does not matter where we find ourselves. Once we are all using the model, we should be able to come up with similar problems for the patient. Okay, the differences that should exist in terms of our intervention should not vary so much in terms of the science and the language. Maybe there may be some slight differences in terms of the calories, but that is being given, or other things, but the science and the quality of care or the problems should all be similar and the same. So it helps us to give that consistency. Okay, so wherever you find ourselves all over the world, we want to ensure there's that consistency and quality of care that we are giving to our patients. It also helps us to provide information on how much and what nutrient to give to the patient. And so when you look at the part of the intervention, it gives you more details about that. It gives suggestions on the nutrient delivery process and the monitoring of key variables. Okay, so these are the key main indicators that the nutrition care process seek to kind of achieve. Now, the question is, I mean, why the nutrition care process? Why the nutrition care process? One of the main reasons for the nutrition care process was that it's intended to give a common language for documentation and communication for all nutrition professionals and dietitians. Okay, in a sense that with the standardized language that was drafted alongside, it helped us to all understand, I mean, the care. Okay, so that when dietitian A is speaking in terms of nutrition care process, dietitian B should be able to understand what he's saying. So if I say that the patient's problem is under the intake category or the intake domain, another colleague dietitian should understand what I'm saying. And when I say related to as evidenced by, I mean, we should all be able to understand why those terms. So it gives us that unique quality to provide the same language for all of us to understand in terms of documentation and communication. It also helps to influence and change the factors that contribute to imbalances and restore and improve what nutritional health. So one of the evidence that came out from the committee was that they realized that the nutrition care process actually was able to bring quality care to patients in terms of giving out patient management, in terms of what the other, compared to other approaches that were being used. So it's a process, or it's a model that actually helps provide high quality nutrition care. And for those of us who have practiced for a number of years, we can agree with me that when you use any other approach, you may miss certain important informations of the patient. You may not get that quality care that you deserve, rather than using the nutrition care process. It also helps to promote the dietetics profession as a unique provider of nutrition care. So it gives us that uniqueness, that it is our trade brand as dietitians. So when we are talking about nutrition care process, we are talking about a trade brand for dietitians, a trade brand for nutritionists, as well as other nutrition professionals, public health nutritionists, or any other people within the field. And so it gives us that unique identity, because, I mean, we cannot use the same process or model other professionals are using. So this also provides us that unique, nature, or the unique tag that we want as dietitians. So these are some of the reasons why the nutrition care process was adapted and put into use. Now we look at the nutrition care process, I mean, and the ADIME approach. What exactly does it entail? So it's basically made up of four, arms. Okay, we have the nutrition assessment, we have the nutrition diagnosis, we have the nutrition intervention, and then we have monitoring and evaluation. Okay, so these are the four things that make up the nutrition care process. So you see that in the ADIME, the acronyms actually stands for each of the arms. So you have A for assessment, D for nutrition diagnosis, nutritional intervention, I, then M, you have the monitoring, and then E for evaluation. So as we go through, we would dig deeper to understand what each of these arms mean and what each of these steps stands for and what it seeks to achieve as far as the nutrition care process and patient care is concerned. So, I mean, I would like to show you this particular framework. So mostly at the top, you have the nutrition screening. Nutrition screening, you only get patients referred either through the doctor or through nutrition screening. So in some facilities or in some hospitals, which Legon, we sometimes tried implementing it. Some facilities comes up with nutrition screening tools. So as soon as the patient is brought into the OPD, there are screening tools that are available that the nurses will look at. And already they pick out patients who are at risk of nutrition and then from the doctors to do the referrals. Then it can also come in the form of referrals through the doctors. Okay, so these are the two things that brings you the patient. And then when the patients come in, as a dietitian, what do you do? The first thing you do is to do nutrition assessment. So in the nutrition assessment, it is the process of data gathering, the evidence gathering. So this is the place where you gather information to find out how or what exactly could be contributing to the nutrition problem that the patient is likely to have. So over there, we have what we call the ABCDs. So we have the A, which is the anthropometry, where you take your weight, your height, your waist circumference, which we'll look at into details later. Then we have the biochemical data, which is the lab values, where you are trying to look at what is happening internally. Then we have the C, which is the clinical. The clinical data consists of two different information. One is the client history, and the other one is the nutrition-focused physical findings. So those two make up of the clinical assessment, and the last one is your diet history. So when you use the ABCDs, you'll be able to remember and capture all the important arms of the nutrition assessment. Now, after you have assessed, what next? You need to diagnose the problem. In the nutrition diagnosis, it is where you label the problem, okay? So after assessing, it helps you to be able to synthesize the data and come up with a nutrition label or problem. And then when the problem is identified, you put in your intervention, which we'll be talking about later into details. And then after that, you monitor and you evaluate to find out whether your intervention has given you the needed, data or the needed, results that you desire. In case you monitor and you realize that the intervention is not working, you have to redesign the intervention again. So you go back into the assessment until you come up with that particular problem that will be able to put in intervention to help the patient to be able to get the best outcome. So remember, the intervention is not the end. You keep redesigning until you get your results. So this is the framework that was brought up by the committee after the committee came up with the model. So I will just briefly explain that. So in the inner core, we have the patient, we have the client or the group, and we have the nutrition professional who is in the inner core. Then surrounded by the inner core, that is the next inner core after this is the nutrition care process. Then out of it, you have your dietetics knowledge, you have your code of ethics, your evidence-based, your communication, critical thinking ability, and then collaborations. All this come together to be able to help you provide the best of care. Then, of course, as you are doing this, you are also looking at the broader context of the social systems in which the patient or the group or the individual finds himself. You are looking at the economic situations, you are looking at the practice settings, and the healthcare system. So all this, you look at all this holistically to be able to come up with the best intervention that will be able to help bring the best quality care for your patient. So this is basically what the framework seeks to achieve. As we go through the presentation, we understand into details the different arms that is found here which includes the nutrition assessment and the others. So the first thing we want to look at is the nutrition assessment, which is the first step of the nutrition care process. So what basically is the nutrition assessment? So nutrition assessment is a systematic process of obtaining, verifying, interpreting data in order to make decisions about the nature and the cause of the nutrition-related problems. Okay, so one key, term you want to take note here is the systematic process. So it is a well-structured approach. And when you look at the care, I think that the committee did a very great job, because when you follow the step, you are not likely to miss the nutrition problem, and that helps you to be able to give the best outcome for the patient in terms of intervention. So the systematic process, it should be structured, okay? So this point of the assessment is the evidence gathering point, where you gather all the data that you need, and you synthesize that data, and applying the rule of critical thinking, you are able to connect the dots and look at the logical connection of all the information you've gathered. And that helps you to be able to come up with the nutrition problem. Then we also want to look at what does the nutrition assessment consist of. So it's made up of one, so you can use the ABCDs, it's still the same thing, to be able to come up with the different arms of the nutrition assessment. So this is not actually arranged in the ABCD order, but if you want to go through the ABCD format, we can still do that. So A stands for anthropometry. So that's the third point. So the nutrition assessment, anthropometry is one of the first arms that is made up. So here you are looking at the dimensions of the physical bodies of the patient, okay? The measurement of dimensions of the physical body of the patient, trying to find out the amount of fat-free and the fat, and the fat mass, to be able to help you to tell the nutrition problem. So here you collect information on your weight, you collect information on your height. If it's a child, you look at the growth pattern, looking at the BMI for age, looking at the weight for age, and any of the growth pattern developed by WHO. Now there is research showing that as part of this anthropometric measurement, we should try to add the waist circumference and the waist to hip ratio as well. So I want to encourage us in our practice, for those of us whose settings allows us to be able to do those measurements, let's add it because it provides a more detailed and a more positive outcome in terms of the anthropometric measurement. So the A is the anthropometry. So there can be several data that you can gather from here, which we'll look at into details as we go through. Then the next thing is the B, which is the biochemical data. Now, one of the things we do as practice, mostly we are always able to remember the biochemical, but we mostly tend to forget the medical tests and analysis. They are all part of the biomedical data. So sometimes a patient who has a stroke may go for a scan. So it's also part of the biochemical synthesis of the data. So sometimes it's important to read the outcome of the report of the scan. Okay, I know that in our practice, sometimes we are not trained as to how to interpret those scans, but at least the report that is attached will still give you some information as far as your biochemical assessment data is concerned. Then we have the C. So the C is the client history. So the client history is made up of the medical history, the personal history, the family and social history of the patient. Okay. Then aside this client history, another C would also include the nutrition focused physical findings. Now, when you use the ABCDs, sometimes when people are using the ABCDs, they tend to forget about the client history. So they will interpret the C as maybe clinical findings, which would also mean the nutrition focused physical findings. But the C, which includes the clinical data, would involve both the client history and the nutrition-focused physical findings. So under there, you look at the physical appearance, you look at fat loss. We've done a lot under the nutrition-focused physical findings by Prof. Laurie and team recently with the CPD that was organized by the people, the Kolebu team, as well as the training that we had at UGMC. So a lot of, knowledge has been impacted as far as nutrition-focused physical findings is concerned. Then the last thing is what we call the diet history or food or nutrition-related history. So you take information on supplements, the knowledge, the beliefs, the physical activity, and any other relevant information that can help you level the nutrition problem. So these are the key things that makes up the nutrition assessment. So you can decide to use it from the perspective of the ABCD, but always remember that your C would include both your client history and your nutrition-focused physical findings as well, so that you don't miss out. I think that the arms are made up of, there are 5 different arms of the nutrition assessment. And sometimes it is always common when you see people ignoring the client history. It's very, very important. So when we're using the ABCD, let's not forget the client history, because it's always easy to remember the focused physical findings. People are able to remember the biochemical, anthropometry, and then also the nutrition-related physical finding. But when it comes to the client history, then it becomes a problem. Diet history is always not a problem. And we've seen this even in student exams where most of them come and they focus on only 4 and leave 1 out. So this is a humble appeal. Let's take note of the client history. It's very, very important, and that can help you to come up with the best outcome for your patients. So the historical information in nutrition assessment is made up of these 3. So these are the 3, historical information that you will need. So medical history, social history, and diet history. So under medical history, you want to find out the current complaints, the past medical conditions, the family history of the illness, surgical history, medication history, use of dietary or herbal supplement. Most times, once again, we forget about the medical history. Okay, it's also very, very important, because all this helps, especially when you have information about the use of supplement, the use of multivitamin and other things. It kind of help you to know how to fine-tune your intervention. Then under the social history, you want to collect data on socioeconomic status, the cultural or ethnic identity, educational level, living situations, shopping arrangement, cooking facilities. You want to know how the person is getting the meals. Is this person married? Is he buying the food? Or he eats from home? How many of the meals are gotten from home? How many of the meals does he eat outside? All this has implications, and it helps you to be able to identify the problem. And the diet history is also very important. So you can do any of your different arms of the diet history collection process, whether you're 24-hour recall, whether you are using a food record or any other, method. So here you should ensure that you capture information on the dietary pattern of the patient, the dietary restrictions, the use of alcohol, food allergies, and intolerances. You want to look at all that, the chewing and swallowing ability. Okay, so you want to assess all that and get information on it so that you know whether you need to modify the texture of your meals or not. And then you need information on feeding assistance. So this historical data, when you group them, the medical and the social history will form part of the client history. The diet history will form part of the food and nutrition related history. Okay, so it's still, belongs to any of the ABCDs as I earlier discussed. Okay, so we move on. So we'll look at the dietary assessment methods. This is something that we are all familiar with, so I would not waste a lot of time. So we have the 24-hour recall. We have the food frequency questionnaire. We have the food record and direct observation. With the 24-hour recall, it helps you to get information of what the patient ate or drank within the past 24 hours. And it has its shortfalls. So mostly it is important to combine at least 1 or 2 dietary assessments than just using one. One of the problems with the 24-hour recall is that it relies heavily on memory, and most patients may not be able to give you the accurate data. It also limits you into collecting information of what happened just that past 24 hours. And if the patient was doing other things right, you may miss certain information on it. So a careful combination of any of these 2 assessments would help. And for a new case, it's always important to have what we call the usual food intake. That kind of helps you get a broad perspective of what the patient is eating, including all the meals. And then you can add a food frequency, which will tell you the pattern of intake of certain foods in terms of the fruit and vegetable intake, in terms of fat intake, in terms of other key variables of or certain food groups. Okay, then the food record is also there, where the person actually records the food that he or she eats, and then with all the portions attached. Always ensure that the patient has the food portions. It kind of help you to be able to quantify what the patient is taking in terms of quantities. A food record without the food portions, it becomes difficult. So you can teach the patient to use normal household measures to be able to do that. Then we have the direct observation, where the professional observes the food that the patient is taking through direct observation. So you can feel free to use any of these dietary assessment methods to be able to come up with your diet history or food and nutrition related history. Then we look at anthropometric measurements. Okay, so this I've even touched on earlier, so I'm not going to spend much time. So we'll look at the height and the length measurements. We know that in children, it's always important to do length, especially children who are less than 2 years. So we don't check the height, we do the length measurements, because it helps to give the best accurate measurement for children of that age. If it's an adult, you can do your height. We can check your weight. When you are checking the weight, you must ensure that you get the valid weight, especially when there are other factors that can affect the outcome of your results and in terms of weight. The bioelectrical impedance analysis, which most of us use, which is the fat analyzer, can also give you some data. You can do the waist circumference, which I'm talking about. In most researches, they would require a waist circumference instead of just a BMI. Then you can check the abdominal guide. You can check the mid-upper arm circumference if it's a child, and you can look at skin fold measurement as well. All right, so these are some of the anthropometric measurements that you can look at. The next, nutrition assessment, which is biochemical assessment, which you want to capture in your nutrition care process, and when you're also documenting, is the biochemical analysis. And what does it do? It literally helps you to determine what is happening in the body internally. So it involves analysis of blood and urine samples, which contains proteins, nutrients, and metabolites that may reflect a nutrition status. And then it also gives you lab values that would give a clearer picture of what is happening. And once again, when you combine the biochemical data and other assessment data, it gives you an objective view of what is actually happening or what problem the patient is likely to present. So biochemical data is very, very, very important. And so if you are seeing a patient and you don't have access to that data, it's important to ask for that information. From experience, you see that some doctors will just refer a patient to you. There are no labs and they expect you to see the case and do magic out of it. We should always insist and expect that they give us all the necessary information that we need to be able to take care of the patient so that we can give the best quality care as much as possible. Then we move to the physical examination, which is under the arm of the clinical findings, okay? So we basically, mostly we say the nutrition-focused physical findings, which is one of the language that we use. So here, a lot of training has gone on, so I will not really waste my time. But here, what you are trying to do is you are trying to assess the patients to find out whether there are other problems that can visibly be seen that would show or predict the nutrition problem. So you look out for muscle wasting, you look out for loss of muscle power, you can assess the loss of fat stores, look out for peripheral edema, skin rashes, angular stomatitis. We can look at glossitis, hydration, and abnormal nail abnormalities and gingivitis as well. So most of these things should be done in a very systematic and chronological manner. For me, one thing that has helped me is I try to do it systematically right from the head. So you assess from the hair, you look at the eyes, you look at the temporaris muscle, then you come to the chest area, you look out for the clavicle, you come to abdominal level, all the way to the feet area. When you start from the head down, it helps you not to miss anything. Okay, somebody can also start from the feet all the way to the head. However, that helps you to be able to do the best physical examination. You can feel free to use any method, but when you don't have a chronological systematic approach, you may miss out on certain important things because you see that after assessing, you realize I should have assessed this part, but because you didn't go in a very chronological manner, you may have left certain information and it will be back and forth, and that does not help you to get a full picture of what is happening to the patient. Then we look at some critical thinking when you are doing nutrition assessment. So mostly you look out for the verbal and nonverbal cues to guide you during your interviewing methods. Whilst you're asking the questions, you observe the patient critically. Most of those verbal and nonverbal cues give you a lot of information. So some patients, whilst you're assessing, you can see expressions of pain. Then you know that, okay, there's some pain. You need to find out where the pain is. Could this pain be related to a nutrition problem? And there are other important verbal cues that you look out for. Whilst doing this, you must have in mind that you must apply critical thinking to be able to help you determine the appropriate data to collect. So whilst you are doing your assessment, you must always ensure that the tools and procedures that you are applying is in a valid and reliable ways, distinguishing the relevant from the irrelevant data, and then organizing your data to relate to the nutrition problem and determine when the problems require what a referral. So all these, things kind of requires a critical thinking approach, because the informations are so many that if you are not careful, even though you may follow the process, you may miss out, or you may not be able to synthesize the data well. And so you may miss out on one of the most important things, which could probably have led you to your nutrition label or the diagnosis. So these are some of the things you have in mind when you are doing the nutrition assessments. All right, so we move on to the next step, which is the nutrition diagnosis. So with the diagnosis, there are standardized language that dietitians and nutrition professionals use. And the IDNT actually makes it very easy when it comes to nutrition diagnosis. And so they have even published a book, the IDNT reference manual. I think there's an updated version, and there's also a soft copy, but I think you have to pay some amount to be able to access it. And this is the reason why we are re-emphasizing that we should join those international bodies like the Academy of Nutrition and Dietetics. I think that they provide some of these free resources. So under this particular step, your main problem is you are trying to identify the specific nutrition problem that the dietetic practitioner can independently treat, the specific nutrition problem that the dietetic professional can independently treat. Now, if you cannot independently treat the problem, then it's not likely a nutrition problem. Okay, and one of the things we have always been emphasizing is that a nutrition problem is not the same as a medical problem. They are two different things. So for instance, the nutrition problem, one of the key questions you ask yourself is, can the dietitian independently treat this problem? If yes, then it's likely qualified to be a nutrition diagnosis. Okay, can the problem change? Because nutrition diagnosis is most likely to change, okay, but the medical problem most times do not change. For instance, type 2 diabetes is a medical diagnosis, okay? So when a patient has type 2 diabetes, it's not likely that the problem will change. When you look at nutrition diagnosis, the possible best example could be excessive carbohydrate intake, which is the nutrition problem. Can the RD independently manage this? Yes. So this means that the excessive carbohydrate intake is qualified to be what? A nutrition problem. And this problem can change by your next review. Okay, so maybe the next time it may not be excessive carbohydrate, but it may be that the person is already on diet, but lacks the willingness to change. So that becomes a different problem altogether, which you need to use motivational interviewing to be able to get a patient to apply. Okay, so the nutrition diagnosis is mostly based, there are key terms that we use in the IDNT to label the nutrition problem, which I'll be showing you later. But it's made up of 3 categories. We have the intake category, we have the clinical, we have the behavioral. We'll go into details later as we move through the presentation. So what is the intake problem? So let me add that in the diagnosis, we use what we call the PES statement, where P is the problem, the E is etiology, and then D, and then S is signs and symptoms, which we'll look at later. So PES statement, so yes, intake, clinical, and behavioral. Then let's look at each one after the other. So
one word wreckage. Why do you leave space?
I think that
now
with most dietitians, I think that one of the main key thing I want us to take note is that we focus so much on intake problem and forget that there are other domains. Okay, we forget that there are other domains. It's not just only intake problem. So you see that most of our PES statement is more of intake problem, but you can have a clinical domain issue. You can have a behavioral environmental problem, which we'll look at later, so that we understand how to use these terms. So the intake problem actually looks at problems related to intake of energy, nutrients, fluid, bioactive substances through oral diets or nutrition support, which could be enteral or parenteral nutrition. So when you say the intake domain of your nutrition diagnosis, so when you identify the problem, the first question you need to ask yourself is that which domain does this nutrition diagnosis fall under? Is it an intake problem? So the question is, if it's related to oral or maybe enteral feeding or anything that has to do with intake, then it's qualified to be an intake problem. So you can have classes, it could be under calorie energy, could be under oral nutrition support, it could be a fluid intake problem or a bioactive substance or nutrition balance. So for instance, excessive energy intake is an intake problem. Okay, so that will fall under the energy balance or calorie or whatever domain here. Okay, then swallowing problem, difficulty swallowing is an intake problem, which can fall under the nutrition support. Okay, so you look at the different types of intake problems, and then you know whether it is really an intake problem and which of the class that it involves. So example could be excessive energy intake. You could have what we call excessive fat intake, excessive protein intake. We have maybe other nutrients or excessive intake of a mineral. You specify the type of mineral that you are talking about. So all these things form part of the intake problem. And the IDNT actually has, a standardized language for all these, okay, which I think that later I would look for the manual and share with you. So what it does is that it keeps all the definitions and how these problems should be interpreted and makes it easy for you to understand. So basically, your nutrition diagnosis tries to identify the problem, okay? Then, so after the intake, we look at the clinical, okay? So at the clinical part, it talks about whether the problem is related to a medical or physical condition, okay? So it could be a functional balance issue, it could be a biochemical balance, it could be a weight balance. So any of these classes can form under the clinical domain. So with the clinical domain, one of the examples that you can use is maybe obesity, okay? Obesity, unintentional weight loss, okay? Unintentional weight gain. These are all examples of clinical problems that you can use as a nutrition diagnosis, okay? And the IDN also have a list of all of that, which I will share later so that we can use to be able to help us in our documentation and in our care of our patient. Then the last one is the environmental. So the nutrition diagnosis problem can be an environmental problem. So here, it could be related to the person's knowledge or beliefs. It could be related to a physical activity or function. It could be related to a food safety or access to food. For some patients, when they come to the hospital, there are some patients you realize that their main nutrition problem is lack of access to food. So that will fall under a nutrition diagnosis of the environmental or the behavioral domain. Okay, so the problem is that the person is not getting access, and this patient is going to keep losing weight, and it's very common in certain group of people. So until you get the right problem, if you are not careful, you may be trying to address an issue of the person is not eating, you give a beautiful plan and you realize that the plan is not working because the main problem you probably missed, which is that the person does not have the financial muscle or he does not have the access to food, which could be one of the main problems which needs to be addressed. And sometimes when it's beyond you, you involve other people who can help. For example, I had a case at the ward, which was a child, a newly diagnosed RVI born to a parent who are finding it difficult in terms of socio-economic capabilities. And so after identifying the problem, we realized that they couldn't even afford their infant formula. And so my next stage was, after the intervention and getting to know the problem, was to involve the social welfare. And they came into our support and they applied through Nestle Ghana and they were able to give us a lot of feeds. And that child is currently doing very well. Supposing I missed out on the ability to identify the problem well, I could just say that maybe the child is sick, that's why the child is not eating, and because the child is infected with RVI. But there may be other pressing issues which has to do with access to food. And that is why your client history is very important, because it gives you details to know what exactly to do in terms of the care of the patient. So in summary, the diagnosis, we mostly use the PES statement, which is the problem, the etiology, and then the signs and symptoms. And so I have it here. So the specific problem, the etiology, the signs and symptoms. Okay, so signs may just be the observable or measurable changes. The symptoms are more subjective data. It talks about what the patient feels and expresses, but the signs are what you can observe and measure the changes as much as possible. So they are not the same, but these are the things that make up the nutrition diagnosis. So for an example, let's say that we are looking at a PES statement. So this is an example of a PES statement. So the problem could be excessive fat intake, and then related to, remember that in our standardized language, we use the related to. So you can decide to abbreviate it or you can decide to use it in full. So some people use RT, okay? Then the etiology here is frequent consumption of fast foods as evidenced by, which is another standardized language we use. Then you put in your signs and symptoms, which would be 10% weight gain in 90 days or increase in serum cholesterol to 6.5 millimole per liter. So you can see that clearly this will qualify as a good nutrition diagnosis for maybe dyslipidemia, okay? But when you look at the medical diagnosis, it will just be dyslipidemia, but your nutrition problem may be excessive fat, and the problem may be that the person is consuming fast foods, and then the signs and symptoms will be there, and then you support it with your lab as well. Okay, so this will be an example of a PA statement that qualifies for dyslipidemia. Now, another example in terms of stroke, so we can say swallowing difficulty, which is a problem related to stroke, which is the etiology as evidenced by coughing following drinking of liquids. So this would also qualify as a nutrition diagnosis for a stroke patient. So you see that the nutrition diagnosis, which involves using a PA statement, is entirely different from your medical diagnosis. So let's take note as much as possible. Then we move to the nutrition intervention. So at the intervention level, so after you have been able to diagnose your problem, the next thing is you do your intervention. Now, from experience, I realized that when you do a proper assessment and you are able to get the right diagnosis, and that right diagnosis actually ends up helping you to put up the best intervention. So for me, all the steps are very important, but I would like to encourage other professionals that we should always take a lot of time and spend due diligence in the assessment and the diagnosis so that it helps us to get a problem. Once you get a problem, intervention becomes very easy. You can be addressing a problem which is not the main issue of the intervention, because you can have several problems. So after doing your assessment and your diagnosis, then the next thing is you put in your intervention. So what exactly is the intervention? So at this point, you are purposely looking at planned actions designed with the intent of changing the nutrition-related behavior. So the risk factor, the environmental condition, the aspects of the health status of the individual or the target group. So you put in interventions to ensure that those actions actually result in a change and help the patient to come up with the best quality care. Okay, and mostly it's directed at the etiology and effects of the diagnosis. It's directed at the etiology and the effects of the diagnosis. So let's take notes. Now, there are two main arms here. So the intervention, it consists of planning the nutrition care. That is one. So you just don't put an intervention, you have to plan. So after synthesizing all your data, in a planning phase, you consult dietetics practice guidelines or manuals. Okay, and this, I would want to encourage other professionals to make use of, practice manuals and then guidelines of certain, conditions. So the Academy of Nutrition and Dietetics have several practice guidelines. They have practice guidelines for diabetes. They have practice guidelines for dyslipidemia, heart failure. In fact, it's actually based on research, and it helps very much and makes it very easy for your intervention. We don't have local practice guidelines, so at least some of those foreign ones, international ones can be applied, and you review it when they need be to get the best outcome. For me, I have used the Academy of Nutrition and Dietetics guidelines for managing CKD, and I had one of the best outcomes. It's a case study that I followed for a very long time. The patient who had a COVID and then had eGFR of about 43. At that point, the weight was about 105 kilograms. So when I followed the guidelines and I put in the intervention, after the first 1 month, the patient started seeing improvement. As I'm talking to you now, the eGFR of the patient is currently 80, and then the creatinine has corrected, the urea has corrected. In fact, there has been a total remission. So I'm still following to see whether this patient can still progress back to CKD, but it's not likely. And that is what practice guidelines actually helps you do, because it gives you the best guidelines in terms of the quantities, in terms of the proteins and all that. So it makes your work very easy. So let's be encouraged to use practice guidelines. You review the policies of the health facility. You determine the specific dietary recommendations, conferring with the patient or caregiver, and establishing the goals and expected outcomes. So these are the 5 things that you look out for in the planning phase. Then in the implementation, you are now documenting the care plan. So you document the care plan, you discuss the nutrition care plan with the patient and caregiver. This is very, very important. That is why we always say patient-centered care, because you cannot do an intervention without discussing it with the patient or a caregiver. Sometimes the home situations may not even allow for the intervention. So when you have the caregiver or the patient, they try to give suggestions as to how you can be able to help in terms of putting in interventions or modifying it to make sure that the outcome is easier for the patient to follow. Then individualizing the treatments as warranted and continuing data collection and documentation. So this is the implementation phase. Then for the treatments, mostly we look out for how we can improve the risk factors. So your nutrition problems, you look at dietary modifications, you look at nutrition handouts or the diet plans that we normally give. Then you can even confer with a medic to change some of the medications if it's one of the things that is interfering with your outcome. If there are other alternatives or medications, the physician, once upon discussion, could look at the best option to do that. For managing of people who have what we call blood clots, most times warfarin can be changed with another different medication, which may not have any dietary interaction. So discussing it with the patient kind of helps, and then the physician. Okay, so if a particular medication can interfere with your management, and this should be based on evidence. There should be a scientific rationale around whatever intervention you are putting across, and then it should be based on high quality research. So sometimes you even have to review researches before you come up with your intervention. Then you set out the goals, okay? The goals of the intervention should be measurables and should be measurable outcomes. You should discuss with the patients, okay? And then you should have measurable goals. Sometimes we set goals that are not measurable. So you want the patient to lose a certain weight, you need to ask yourself, is this goal achievable? So we take note of all that. Okay, so the goals must be achievable. It must be stated in behavioral terms. The counselor must establish the goals together with the patient, and also involve the healthcare team. Sometimes you need to even involve the doctor as well. So an example of an intervention for an involuntary weight loss, in your documentation, it could come this way. A patient will try to eat 3 meals a day plus bedtime snack, include at least 1 nutrient-dense supplement per day in his diet. That is if it's needed. Patient will increase energy intake to 1,800 kilocalories per day and complete a 3-day food record for analysis of adequacy. So these are intervention or goals that you can set with your patient for the next visit. Then we come to the monitoring and evaluation. Here, you are now evaluating whether the intervention you actually put really works or not. So you review the patient intervention as a designated date. So you compare it with the early assessment data and the diagnosis to see whether the intervention goals are met. If the intervention goals are not met, you need to redesign the intervention again until you start getting the results. Now, hospital information system and NCP. This is very important. As earlier on discussed, with the current emerging trend of, electronic medical documentation or hospital information system, most hospitals are moving to paperless. Now, what it means is that nutrition care process must also be documented in any hospital information system to be able to help you, the dietitian or the nutritionist, to be able to do your documentation and do it well. I realize that for some facilities, they do not prioritize this. they will do it for the other professionals, especially the medical team, and then tend to forget about the dietitian. I would always encourage that you insist that the NCP is uploaded into any hospital information system that you are using. And that kind of helps to make your work easy and helps you to document well and also use that particular care process to help in the quality of your patient. The IDN, which is the International Dietetics and Nutrition Technology, has all the data of nutrition diagnosis, okay? It's captured under intake, clinical, and behavioral. So you have all the different arms, and there are terms that are available that can easily be entered into the system. So when you are doing your documentation and you get to the diagnosis, you just click on the diagnosis, then you go to the category you are looking out for. If it's intake and you click, it gives you all the list of possible intake problems. So you can have excessive energy intake, you have excessive fat, excessive sugar intake, and all other intake problems. And once those problems are there, it kind of makes it easy for your documentation. And then the intervention can even be incorporated into the system. So I am fortunate to be in a system where we have incorporated our nutrition care process and the ADIME format into our hospital information system at University of Ghana Hospital. And it's really helped us. Even for us, we have been able to link our kitchen to the hospital information system. What it means is that any patient diet request that is given, whether the patient selected or the nurse entered it, we as dietitians were able to see. And once you think that the patient medical information is not good, we can easily modify the plan. And even in our system, we have the diabetes diet separately, we have a normal diet. So depending on the condition, you can choose a particular diet, and our kitchen have been trained and understand what it means to say that you are giving a patient a diabetic diet, and they do exactly that, you know, and it's really helped us in terms of outcome, in terms of diabetes management and our patient care. So we can always look at our situation and see how we can incorporate these NCPs into our hospital information system. It's not a difficult thing to do. You just need to sit with them, look at all the processes, and then you can contact me for any of the IDNT terms that you will need to put into that system. And it works beautifully and makes your work very, very easy. So let's not always be forcing to use other professionals' documentation platform. Let's incorporate our own documentation platform. And that gives us that unique identity that we are talking about. So let's be encouraged and see how we can incorporate this into our system wherever we find ourselves. Then basically that leads to the end of the first part of the presentation. So I think that there's a case study which we'll have to go through. After we are done, then if we have time, we will discuss one case study and we'll bring the session to an end and open the floor for questions, contributions as well. So the time is already fast spent, so I'll be a bit brief when it comes to the case study. So this case study, we are going to use the nutrition care process, which is the ADIME approach, for us to be able to understand how we can take care of a patient who is newly diagnosed with celiac disease, and also be able to document it into our system as much as possible. So let's look at the process. So under our nutrition assessment, for a patient who is newly diagnosed with celiac disease, who has no prior knowledge of the condition, one of the first things you want to look out is you want to look out for your 24-hour record or any of your dietary assessments. You can feel free to use any dietary assessment that you think will give you the best of outcome. You want to collect information on the knowledge, beliefs, and attitude of the patient in relation to celiac disease and its diagnosis. And then you also want to look out for relevant eating behaviors. Okay, how many meals the person is consuming, You want to look out for how the person normally eats it, what he's eating, his home situations, where he's getting the foods, and where he buys the food from. Okay, so for the benefit of some of us who may not know what celiac disease is, it's simply an immune reaction to eating gluten, a protein that is found in wheat, barley, and rye. Okay, so it's not so common in our setting, but sometimes you have I've had few cases that have been referred to me, and it sometimes can be very devastating for a lot of patients. So it's a gluten sensitivity problem, which involves the reaction of the immune system. And we know gluten is a protein. So that's what we are discussing. So under your food and nutrition related issue, you must make sure that all this important information are captured. Then overall lifestyle, you look at the history of dieting and other information as much as possible. Then under your anthropometry, you want to collect information on your weight, your height, your waist circumference. If there are weight history changes or weight loss changes, you want to document them and also collect information on that. And then under your biochemical data, you want to look out for some other screens, lab values. Mostly in our setting, you want to look out for full blood count because they may be having diarrhea. I mean, you want to look out for some micronutrient deficiencies like B12, calcium, albumin, and other important labs that you think is would help you come up with the right diagnosis. And then you want to confirm other food allergies. You want to look out at other relevant labs of other conditions. So the person may come with celiac disease, but he may also as well have type 1 diabetes or cholesterol. So you want to look for your FBS, you want to look for your lipids, if there are other comorbid conditions or any other lab that you think is important. And so in your documentation, it will follow in the same trend using the ABCD, and you must make sure that all the important information in any of these categories are carefully summarized into your documentation. And once you have this information loaded into your hospital information system, it makes it easier so that you don't forget it, and it makes the documentation even more easier because all the information will be fully structured and put inside the system for you. Then you do your nutrition physical assessment for this patient. So for a celiac disease patient, you want to look at fat loss, you want to look at muscle loss, whether there's loose stool, whether there's, bloatiness, the bowel habits, digestive issues, pain and all that. So you want to look out for all those informations as part of gathering information for your physical findings. You can look at other micronutrient deficiencies if it is important. So you can do a thorough objective one, but these ones I just separated it out because it's peculiar to the condition or the celiac disease that we are discussing. Then, so your nutrition diagnosis. So what will be the likely diagnosis of this patient? Remember that with the preamble, the person is a newly diagnosed celiac disease who has no knowledge. Okay, so in this case, the problem can most likely be food and nutrition related knowledge deficits related to a newly diagnosed celiac disease, as evidenced by 3-day food record showing consumption of foods containing gluten. So this can qualify as your nutrition diagnosis. And so here you know that at least if it's a nutrition related knowledge problem, with regards to selection of gluten foods, this can easily and independently be addressed by the dietitian. So it's highly qualified for an intervention. So this can be a nutrition problem. So your P could be the food and nutrition related problem. The related to could be the diagnosis of the celiac disease. And then the signs and symptoms could be the 3-day food record of consumption of foods containing gluten. It can be written in several formats. So whichever format you use, you must make sure that it meets the key requirements of the nutrition care process as far as documentation, diagnosis is what is concerned. Then intervention, one of the key intervention you will need to put here, remember you have to plan. So you consult your guidelines, your dietetics manual, So after doing all the planning, some key indicators that the implementation of the plan, you want to look at how the patient can identify gluten-containing foods. So this can be addressed by a nutrition education problem. Label reading, how does the person identify foods that has gluten? You address issues with cross-contamination. You counsel or educate the person on gluten-free food choices. So this is just a summary of some of the key things you need to capture as far as your intervention is concerned. And then under your monitoring evaluation, you track to assess the compliance with gluten-free diets. Okay, so you want to find out when a patient comes back, how is he complying with the gluten-free diet that you have given the person? Is there nutrient adequacy and diet quality? What are the changes in the digestive symptoms? So you want to look at the signs and symptoms. You want to look at changes in labs and nutrient deficiencies, and then want to look at changes in personal motivation levels and factors that may impact diet compliance. This last point is very, very important. There are times you see that the patient knows everything, but their motivation levels are just too low, especially for some patients who are on a weight loss diet intervention. And so you would need to find motivational interviewing and guide to help this patient to be able to get the right intervention and be able to start making progress in terms of outcomes. So that will be the last thing you look out for someone who has celiac disease and does not have any knowledge as far as the disease is concerned. Of course, there could be other nutrition problems that may come up in your interaction with the patient. So I just chose one of the problem and try to address it. So in your documentation, you must ensure that when you are documenting, it captures all these key indicators throughout your assessments, all the way to your monitoring and evaluation. And once again, if this is in your medical documentation, hospital information system, it makes the work very, very, very easy. So if there are people who just write the steps and put in a space where they will type. That may not be effective. If you have the IDN language, all the diagnosis can be entered. So when you are labeling your problem, when you go in there and you go into any of the domains, it gives you all the diagnosis and you use that. Otherwise, you may end up writing certain languages which is not in compliance with the IDN or the nutrition care process language. Okay, so it's important to have all those things entered into the system, okay, so that when you are documenting, it makes the work very, very easier for you. Yeah, so basically that takes me to the end of the case study that I am using for us to further understand how the process should be used and how the documentation can be done. So, I mean, there will be another case study where we will open up the floor for people to share their ideas on this. So I think that at this point, I would like to humbly invite our able chair to come in and coordinate. So what we are going to do is that this is the case study. So we'll look at the case study and go through the steps. We have some few minutes. We have some minutes left, so we can go through these case studies quickly before we open the floor up for questions and additions. And then I think we would have achieved our goal for the day. So the case study is a recently employed 28-year-old lady is referred to the dietitian for weight management. She eats 3 huge meals a day and is constantly sipping soft drinks when she's working. 2 of her meals are eaten outside home at a fast food joint and restaurant, respectively. Her weight has increased by 20 kilos in the past 2 months. Her BMI is 35. So the assignment is that, or the discussion is that, how do we use the nutrition care process ADIME approach to address this problem? And so I would humbly request our chair to come in to help us in the coordination. Thank you so much. And then once we continue through, we'll get soon to the end of the presentation after this case study. Able Chair, over to you.
Yeah, that has been an erudite presentation, Maxwell. So that we will be systematic with the interventions or with our contributions. If you could lead us through, like the way you did the first one.
Okay. Okay.
So let's take the
All
first
right.
point.
All right. That's fine. Okay.
Yeah.
Okay. So we move on to. So what I did is I actually didn't provide any assessment. So we are going to look at the nutrition assessment. So the first thing we are looking at is the nutrition assessment. So over here, we are going to use the ABCD. So we will start with the anthropometry for it to be very systematic and easy to coordinate this. So looking at this case study, what are some of the important anthropometric measurements that will be needed for us to assess this patient in terms of the measurement of physical dimensions of the body? So it's open. So let's kindly share our views.
Please, if you want to speak, kindly raise your hand and I'll call you to speak. We want as many of us to talk at this stage. Yeah, so Maxwell, you are getting a lot of accolades from Dr. Hayford and RD Mavis. Right. Okay, so many people are giving their answers in the chat box. Rosa Adum says that we have to consider BMI and has gone ahead to okay, so the BMI was calculated already, so she's giving that BMI is important, so she's giving BMI of 35. Said maybe says weight gain of 20 kilograms is important to indicate. Yeah, 20 kilograms in 1 month. So huge. Okay, so I've seen Shaibu Isifu. Kindly unmute and speak.
Yes, he's talking about how to go about it using the ADIME and then so I will say that you start with your assessment. You start with the assessment, which is the first part of it. And like what he initially said, you would like to take a little from the client about the food, and that history has been given already. And I think that you also go with some of the anthro assessment, as he mentioned. In this case, I think that your anthro assessment should focus more on the type of obesity that he's suffering from, because you've been given the BMI of 35. So you'll be looking at more of with a hip ratio to tell you whether it's a central, to get inside whether it's a central obesity or the adipose. Then if you are suspecting anything, you can put in the clinical biochemical request for the lipid levels to see whether there's some dyslipidemia somewhere that you want to pick up. Then, of course, the physical examination, so that you can pick any abnormality you can see clinically from the person to inform you about the diagnosis to actually settle on. So I want to talk a little about the assessment, and I think that some of these things will help pick up salient things from the client.
Thank you very much. Thank you very much, Shaibu. Very insightful contribution. Yes, we have Safiano Osman.
Okay,
Safiano, kindly unmute and speak.
Yeah, so thank you for the submission. So like he has stipulated, you'd have to follow the nutrition care process, and we'll start with the anthropometric measurements. So the anthropometric measurements will be looking at keenly with weight management. We'll look at the actual body weight of the person, the actual height of the person. We'll want to look at the BMI as well. You may want to consider the ideal body weight calculation of this patient. You want to consider what we term as adjusted body weight of this patient based on the BMI. You need to do some adjustments when you are dealing with the energy calculations. You want to work on the waist circumference, the waist to hip ratio as well. You want to consider the weight change of the patient. And also you want to look at the body composition variables like the visceral fat, the percent body fat, and so forth. Then we progress to the biochemical data of this patient, where we have the biochemicals. You want to look at the medical test and any other procedures that have been done in the health facility. So if you are looking at the biochemical data, the common ones you want to focus, of course, that has to do with weight, will be the lipid profile. You may want to look out for the FBS of this patient. You may want to look out for then we'll progress to talk about the clinical data, where I'll look at the nutrition-focused physical findings of this patient. You may want to look out for central obesity physically. You would want to probably look out for any edema. You may want to look out for any physical feature that you deem necessary for you. Then we progress to the food and nutrition related history of this patient, where you gather the 24-hour record of the usual intake of this patient. Any food history or dietary pattern of this patient may be considered there. Then you also consider the client history of the patient, where you take the social history of this patient, the age, the religion, and all those stuff could give a great insight onto how to handle the case. Thank you.
Thank you very much, Osman. Very insightful contribution. Please, any other? I think we've done.
Yeah, we've done nutrition.
Yeah.
So I think we can move to the next.
Yeah.
The next step, which is the nutrition
diagnosis.
Yes.
Yeah. So the diagnosis. Do right, please. You can talk. Hello. Edu, your line is breaking. Kindly unmute and speak. Let's see whether it will be better. Okay. Also, you are getting more applause in the chat box. The people are not contributing. They are applauding you. Okay. That's true. Emilia Woody says that she likes how you simplify the terms to everyone's understanding. Great presentation, Maxwell. You are having a lot of big ups here. So please, any Salif, with your hand up, is it a fresh hand or the old hand? Safiano.
Yeah, so this is a fresh hand.
Okay.
So the possible diagnosis we can get here, starting from the anthropometric data, the BMI is a red flag, so we can have obesity related to. So based on your assessment and your energy calculations, if you think that the energy intake was probably greater than the requirements, you could have the diagnosis going in this way: obesity related to excessive energy intake, as evidenced by the BMI of 35 and probably the energy calculation which you did, comparing it against the energy requirement of the patient. You may also possibly get another diagnosis like the same obesity related to, if you think is the dietary pattern of the person that's not well, you may have something like disordered eating pattern, or you may have an etiology like food and nutrition related knowledge deficits. as evidenced by the BMI in the patient's diet history, which has the reports of unhealthy fasting sleep.
Okay, so will you explain a bit more why you are using obesity?
Yes. Okay, so based on the domains, we have the intake domain that our diagnosis can come from. We can have the clinical domain and the behavioral domain. So I'm using it or limiting it to possibly the obesity where I've just spotted in the andros. So as I get my nutrition assessment data, you first to just guide you and make it easy to get a diagnosis, I would probably start with my anthropometric data to see if I can get any form today. So let's assume that I went through and the BMI was what I spotted first. So I can have a clinical domain diagnosis where I have obesity related to. So my possible causes, if I think it's maybe excessive energy intake, that would be my cause. If I think it is food and nutrition related knowledge deficit, that would be my cause. If I think it's disordered eating pattern, that can also be my cause as well. As evidenced by, that would be the BMI and also the energy calculation that probably I did, or if it is any diet history information I can use to calculate diagnosis, that can also be there. I would also get a behavioral coming up, something like food and nutrition related knowledge, if you're being a nutrition problem. It is probably lack of prior nutrition education as evidenced by the MI, the self-report the patient and so forth. We could also have the solid eating pattern being the main cause of starting. Or like we would also have excessive energy intake after intake starting and the nutrition etiology, sorry, nutrition problem related to probably lack of.
Yeah, Safiano, we are losing you. Your voice is low now.
Yes.
Kindly speak up a bit.
So I mean, we could also possibly even have an intake domain started, like excessive caloric intake related to even this food and nutrition related knowledge deficit concerning that base caloric intake, as evidenced by the energy calculations which we've done comparing it to a requirement of the patient. Or we could even have the BMI supporting it as the case. So those are some of the possible diagnoses we can have.
Excellent.
All right. Sophia, you've done so well. I think that the obesity is under the clinical domain, as you rightly put it. So you can decide to go through the intake domain or the clinical domain. So in the clinical domain, I think in the IDNT, that's the terminology reference manual, I think obesity is actually captured as a possible nutrition problem. So I think you did well. You captured both. Thank you.
Any other person, please? Okay, so I think we may move on. Yeah. To our intervention. Safian again. Yes, kindly go ahead.
So for me, the intervention, I'll probably want to state the domain of nutrition intervention I would apply. So based on the assessment, if I think I should apply the nutrition counseling or nutrition education domains, which usually I think they go hand in hand, nutrition counseling and education. So those would be my main nutrition intervention. Then I'd have to set my goals for this patient. The goals will be set based on my evidence I have in the diagnosis. So if I pick an example like the obesity case where probably my evidence has to do with the BMI, and probably my evidence will have to do with something like blood pressure being an evidence of that sort. Those will be part of my goals I would want to set. What points of the figure am I hoping to reduce? If it has to do with energy intake as my evidence, I'll probably want to set my goals based on energy intake. Say probably to reduce this patient's caloric intake from probably 4,000 calories to 30,000 calories within a week or two. That is up to you, the professional, to make that judgment. So I think basically that's where the interventions would block up. Then you probably implement it by communicating your diagnosis to your intervention to the patient, where you put them in the action form like rightly stated. The patient may have to probably adjust to their dietary patterns. So either they are going to introduce fruits, their meals and so forth. So that's like that. Thank you. Okay, sir.
All right. Okay. Any other person, any other contribution, please? Any other contribution regarding the intervention? Please, are we all here? Or we want to close? Anybody? Okay, so if you can just unmute and speak if you have any contribution now, so that we can make time.
All right, so we move to the monitoring and evaluation then. I think that Safiano has done well. He's given us a lot of information in the intervention. Because of time, we will move to the monitoring and evaluation, and then we open the floor for questions so that we can be on time. So anybody? Safiano, will you want to come again?
Okay, yes. So
yes,
you monitor your goals and also monitor the assessment data as well. So despite the patient coming in, the key ones you want to look at is to monitor your goals, what you seek to achieve. But the case that the patient may had come to you on the first encounter has good results, but on the next encounter probably would have some of the figures altered. So you reassess the nutrition information again. So those are what you monitor.
Okay, so in this particular case, if we can prove further, what are some of the stated goals we can give so that you can monitor? What are your weight goals? What are your lab goals? What are some of the things we can so that we can use them as?
Okay, so let's pick an example where let's work with the energy intake of the patient being one thing we want to consider. So in that case, if my goal is to reduce the caloric intake of this patient from, let's say, 4,000 calories to 3,000 calories, that would be what I would want to monitor in the next encounter. So that energy intake would be something you'd monitor on your next encounter. You may also want to look at the weight goals as well. If you seek to probably reduce the patient's weight by 0.5 kg in a week, or 1 kg in a week as recommended by the WHO, you may want that will also be part of your monitoring variable on the next encounter.
Okay, thank you. Please, any other person with any other input regarding the MNE? Okay, I think the presentation has satisfied many people. So this one, like of them, what I saw earlier. Hello, Dr. Asiedu.
Yes, good evening.
Good evening.
Yes, to add to what the gentleman who spoke earlier mentioned, I remember he indicated that part of his intervention was going to be to look at the dietary pattern of the client. So for monitoring and evaluation, he could also look at his current dietary intake. What are the things he's eating? He or she is eating. If she's been able to change the kind of things she was eating, the energy dense sugar sweetened beverages or the bulk portions that she was eating, it's another thing he could monitor to see if there's been any change when the patient comes for monitoring and evaluation. Thank you.
All right, thank you so much. Thank you very much. All right. I think the expression of all of us have actually indicated that whatever RD Conland, or what I say, RD Maxwell, has taken us to have actually sunk in well. Safiano, do you have anything else to add?
Yes, I just had a few contributions I wanted to make.
Okay, please, before you come, Emilia, kindly unmute and speak.
Okay. Hello. Please, can you hear me?
Yes, we can hear you.
Okay. I just wanted to ask one question and then one comment or contribution. Is it okay to?
Yes, so we will answer the question during the question time, but we can go ahead.
So can I go ahead?
Yes, go ahead.
Oh, okay. So the question is, I think in the nutrition assessment, I saw abdominal GERD and then waist circumference. I just wanted to know what's the abdominal GERD, what differently will it tell us from the waist circumference? So that is the question. Then the comment is, I think he made it clear that one of the challenges that we face when we are taking clients through interventions is the lack of motivation by the clients. So I was thinking that if there's a way that the leadership or the organizers can get us maybe a presentation or a panel discussion on how to go about motivational interviewing or intervention, I think it will help us in the profession a lot. So if RD can just also chip in, if he has the time, he can tell us what to do, or then we go on to the organizers to help us with this area. So that's it. Thank you.
Okay. You have suggested a new CPD topic. Well taken. we'll put it on the bill, and okay. I think for this year, maybe I don't know whether the zones can think about it, but for this year, our hands are already full, so it may find expression in the subsequent CPDs. Yeah.
Okay. Thank you.
All right. So Safiano, you can do it. So I think that will be the last comment to take. Then we will enter into the question and answer session.
Okay. So I think it has to do with the term, the IDN. I think the term has kind of been modified, or it has been changed way in 2014 to now mean the nutrition care process terminology. So it's now referred to as the NCPT. And my other suggestions too was also that if you follow the history of this nutrition care process terminology, which now exists, which was formerly the IDNT, it was established by the AND, the Academy of Nutrition and Dietetics. Then we realized that the other associations, especially the British Dietetic Association, adapted this to also have their own model. So they have what they use as the model and process for nutrition and dietetics practice. So they have the components which we are familiar with, the A, B, C, D, E, and currently they've added an F. That's way from 2020. So I was looking at and as an example, currently we include body composition assessment in our hospitals using the body composition monitors. We can have GAND also setting in to establish a model based on this AND and the British Association one to fit the Ghanaian models and the Ghanaian setting. So we also have one on our own. Because what I've noticed is that the British have their hidden anthropometric measurements written as anthropometry and body composition, which I think that can reflect our setting too. They have their biochemical data. So in that regard, I hope my point is clear. And look, like he rightly mentioned, RD Maxwell mentioned, I think we have clinical guidelines, lots of clinical guidelines available, which could be picked from the Academy of Nutrition dietetics. They could also be picked from the American Association for Parenteral and Enteral Nutrition, ASPEN. You could also pick them from the European Society for Clinical Nutrition and Metabolism, which are current, and I think we can make good use of them. So I was hoping if GAN could take an initiative to get these down, to have something we can call our own, something of Ghana, that could also help.
All right. Okay. Thank you so much. Thank you so much. We have a few more minutes to go. We'll open the floor for questions. So, Maxwell, you can take the first question.
Yeah.
Abdominal GERD and abdominal.
Yeah. So the abdominal GERD and then the waist circumference is basically the same. So the abdominal GERD is measured at the point of the navel, which is the same as the waist circumference, and all that's seek to kind of find out the abdominal obesity situation of the patient. Okay, so they can be used interchangeably. Now for the helping a patient to adapt to change is very, very difficult, as you are saying. Yeah, I mean, at a point at our clinic, we had one patient who keep coming. When you give her appointment, come in 1 month, exactly when the time is up, she's there. But when you do the assessment, you see that the weight is not coming down. So such people, mostly one of the things they lack is motivation. So their nutrition problem may be a lack of willingness to change. It's not just because they don't know. They know everything about what they're supposed to do, but they just find it very difficult. So that's why where you try to apply the principle of motivational interviewing, I think that calls for another CPD, as chairman has said. So I think at some point we may have to get an expert to come and take us through motivational interviewing and how to get people to adapt to change. Okay, so there are various processes that you lead a patient to adapt to that change. But based on my experience, what I normally do is I try to find out why this patient is not willing to change. Now, once I identify the problem, I engage the person and let the person know that, look, we've done everything. I know that you want to do this, but I've identified that this is your problem. So when you are able to address the issue or the reason why the person is not able to abide by the plan, sometimes it helps them to get back to do better. Yeah, so basically those are some of the few things. So for children, you do motivation, like sometimes you tell them that if you lose this amount of weight, you give the child a present. So some of the things that you apply for children. Yes, please.
Yeah, Josephine. Josephine.
There is no sugar. Nana Coco did ban. Or go and take food.
All right, so Mazi, please go ahead.
Yeah, so basically, I mean, those are some few things you do. Because for most children, if you don't motivate them, but you don't motivate them giving them food. So mostly we give them things that they can learn. So we promise that, okay, if you lose this amount of weight in the next, daddy will buy this, or even the dietitian. And I've seen that work for most children that I've taken care of, because they tend to put up their best because they want that price. Unfortunately, sometimes you have some children asking for things that are very costly that may not be within the budget of the patient. So sometimes you have to renegotiate and get something easier that you can reward the child with in case he's able to meet the targets. But it's very difficult. It's not an easy thing. So we need an expert to help us in that.
All right. Okay. So I think I'll allow one last question, if there is. One last question, then we'll take announcements and call it a day.
Yeah, hello.
Yes.
Yes, sir. Please, I'm ADIME.
Yeah,
sorry,
right.
I was having some challenges with my network.
No problem.
So I don't know if you can please share the audio with us or the slides, if possible.
The slides. Oh, okay.
Yes, please.
For all the recordings, all of them will be pulled and we'll upload them and give you the link to it.
Okay.
Yes, with the slide, we'll see. Once all of you registered, we could send them to you by email.
All right. What of the form, the attendance form? Is there a form that we need to fill?
The attendance form is in the chat box.
Okay.
Or did you drop?
Yes, I dropped along the line.
I've put it there. Kindly fill.
Okay, sir.
I've just put it there again.
Okay, thank you.
Welcome.
Also,
yes, madam. That is the chairman of the dietetic group. Yes, please speak.
Okay, so yes, thank you very much. RD Maxwell, thank you very much. You just nailed it. So simple and it's practical. So I just want to commend you for a very good work done. But just to add on to the motivational counseling, you know, it is a major topic that will be handled, and the chair has said that will be considered. We will add it to our table, maybe our next year CPDs. But we are still seeing patients. So what do? It is important we share our experience as professionals, and it's worth for each and every one of us. So I want to share just some few minutes experience, how I go about with mine, and it really works so well for me and for my clients. As RD Maxwell rightly said, change is very difficult. And sometimes you get some patients who are so difficult, before they get there, they have moved from all departments before they get to the diet therapy department. The diet therapy department is the last point in most cases. The patient is exhausted in terms of energy, is exhausted in terms of finances, is so frustrated. The patient comes there and the patient knows that, oh, I am just going to, in no time, I'll hang my boots. But that is not it. It's for us, and that is why it is important. As soon as the patient gets there, our environment, most of the times, is not too comfortable for them. That privacy they need, we don't have it. But again, our personality as professionals will make the patient have some confidence in us. And then, so communication is key. The first point is communication at the reception. How was the patient welcome at the reception? This is something that we'll have to look at. Then the assessment area. Before you assess the patient needs to be reassured. This is why I am doing this ABCD. Then the steps keeps going. So the patient gets to the final person, which is the RD, who will cancel. Your first welcoming smile is something that is a powerful healing that no medicine can take care of it. No surgery can take care of it. That welcoming smile, very, very important. So please, let's take note of that. Then communication, what language? Let the patient feel very comfortable. If you are fortunate to have to speak if you are multilingual, you will find out from the patient what language the patient will be comfortable in. And then just start, don't start with the case. Start with something that is liberal, something that will put some smiles on the patient's face before you can start. Then you need to collaborate therapeutically with the patient, because our purpose is therapeutic healing. How are you starting it? Collaborate with the patient. You are not the one who, it is the patient, the patient has the right to the management. So you collaborate with the patient therapeutically. Then you set the goals together. After setting the goals together, you agree that where we have started, It is not a one-day job. This is where gradually we will get there. So I think it is a step by step. And then finally, empathy, sense of empathy as professionals, sense of empathy. Don't jump to conclusion. If it is review or new case, oh, so madam, all that we said, you didn't do well. You couldn't even take 0.5 off. No, it's discouraging. Wait till you are there. Then you know that even taking off 0.1 is a huge tax. So empathy. So as dietitians, let us play our duty. Let us display our professionalism with our hearts. Let's display the professionalism with our heart. And that is the sense of empathy. I'll just pause here and then, because as I started, I said it is something that is huge, but this is something that we can share our experiences. So this is a little that I want to add. And I want to say kudos to RD Maxwell. Well done. And to everybody, all the RDs. The attendance was huge. Thank you all.
Yes, we had averagely 125 attendance.
That's great.
So the chair of the dietetic group, RD Hamdaratu, or AKA RD Hadia. Yeah, thank you for your contribution. Please, our time is up, and I want to say a very big thank you to all of you for making it. Hey, Hadia, you are looking great, oh. Yay, your goggles are very nice. Okay, all right. So please, on the 26th is our next CPD. 26th is the CPD being run, is a nutrition specific CPD, but I think as dietitians, it will also be helpful to us. So if you want to join, you are free, but it is on the zonal basis. And it's going to be in person. So if you are in the northern zone, please kindly join. Those of us in the middle zone, do your best to join. Those of us in the southern zone, please join. Western and Central, and Eastern and Western, Eastern and Volta. Please, let's do our best to be part. We want to build our base with our CPDs. This one was supposed to be zonal. But we had a bit of challenge having all our zonal speakers at a go. That's why we had to bring it together. But subsequently, all our zonal CPDs will be in person. Thank you so very much. When we close, I'll be online for about 5 minutes to allow those who are here to fill the form to finish before I close up. God bless all of you. Enjoy your day and be the best dietitians you can ever be to your clients. Thank you and bye-bye.
Bye-bye.
Thank you very much, RD Maxwell. God richly bless you. And I think you have discharged yourself creditably. And this one calls for a repeat. So you'll be invited again. Yes.
Thank you.
I can see RD Beko, RD Beko Nate. I can see RD Efua and Jonathan, Justine Kumsin, RD Yannick, Dr. Anderson. I've seen all of you. Thank you for joining. God bless all of you for your support. Tina, I trust you are good. RD Bobo. Yeah, okay. Hey, Alice, I can see you. RD Pamela, Phoebe, Sherin, Rita, Joycelyn, Samson. Hey, Samson, how is it? And your team?
Doing
Hi,
well.
friend. How are you too?
We are doing well by grace. Yeah. Justine, you are not talking. I thought you were going to talk. Okay. RD Mesa. Hey, Chief.
Am I the one in question?
Yes, you are the one in question.
Hello,
You are the one in
everyone.
question. Yeah, good evening. How are you and the family?
We are doing great. Thank you.
Right.
Thank you, Maxwell. It was a great presentation.
And hey, Chief Ruby, I salute. Hey, Mayu, it's a long time I heard your voice. So, Mayu.
Mayu has taken a French leave.
Yeah. She's hiding in the doldrums.
Sorry.
Hey, Ernestina, yeah, chill. Welcome.
Thank you. Hi.
Yeah, fine.
Hello.
Yeah, Tina.
Yeah, it's been a while.
Yeah, so I heard you are reading 10 papers an hour.
Hello, how are you, Prince?
Yeah, Chief.
Yes.
I salute.
I salute back.
I'm fine.
I'm doing fine. Thank you so much. I'm doing great.
Yes.
I hope everyone is doing well.
Yes, please. Everyone is fine. Regards from YP2.
Okay. Thank you. Okay, God bless us all.
Yeah, you are taking very good care of Phoebe. The chicks have come.
Yes, she's looking good. Yes.
Yeah.
I know. Thanks.
Tina, the bank. Any money for us?
Oh, some will be popping into your accounts very soon.
Sure. How did Tina? Any money from the bank? Okay, so I think everybody have been able to fill the form. So we can end the meeting here. Please enjoy yourself and take very good care of your clients. Thank you very much. Bye-bye.